All right, here we are. A&I. What year is it?
2020.
2022. One of my buddies, Mike Sims, in the industry.
Good to see you, buddy.
We've known each other. We won't tell the audience how many years.
Been wonderful years, though.
Yes. Thanks for coming by.
Thank you.
Thanks for contributing to the dialogue. So you know the topic, right? We're chatting about it. It's really just to get the conversation going with leaders in the revenue cycle. We often talk about like healthcare is a decade behind, right? That's the consensus. I think it's probably maybe even a little longer when you look at other industries like fintech and technology in general. So what's your take on that? Like, how do we leapfrog? What are we going to do in the revenue cycle to improve yield, address waste? There's so much waste in the revenue cycle. Like, can we have a leapfrog moment just to kind of get the conversation going?
Well, first of all, I'd like to thank you for what you've done, you and your organization. You know, VisiQuate, without VisiQuate, data analytics, you know, Epic doesn't provide the best in data analytics, so we need a partner like you. Yep. So first of all, thank you for what you do.
Thank you for that. Appreciate it.
So that's part of that innovation, right?
Yeah.
Things that you're trying to do, okay, for instance, with the payer communication channel that you're trying to develop.
Right.
So I think that that's very important. What I see happening is we're starting to move more into technology such as artificial intelligence, okay, anything to increase productivity and efficiency, because we do have a lot of waste. We touch too many accounts. I was just in a session here at HFMA talking about building a real communication channel with the payers. So that we both spend a bunch of overlapping time. And so if we develop that communication channel, that we share data amongst each other so we don't have these repetitive tasks. So I think as far as innovation goes, it's just going to keep getting better and better. And we've even had some fintech firms such as patient financing that has come along to improve the technology. So I think you're right on.
When you pick something like that, and we were talking earlier about, you know, partners, maybe we can just do that. Like the kind of innovation, AI, machine learning, it's buzzword soup, but it typically requires, most people acknowledge, bringing in partners, right? Because we geek out on AI and machine learning all day. But what's your process? Like, how do you think about the right partners when you, first of all, how do you think about what to automate? Do you guys have a process? And then once you decide, hey, we're going to put some money in this part of the revenue cycle, what's your process to think about partnerships?
Well, I'll give a perfect example. We're trying to automate the authorization process. And so there's a bunch of partners out there that say that they can do everything from day one, right? And it's really not true. So what we look for in a partner is somebody that has a differentiation, somebody that brings to you software or technology that is state-of-the-art, that is going to accomplish what we need to do. For instance, right now we touch too many accounts to go back and forth with the provider's office to make sure authorization is done. We need a seamless process where once the order is placed, that authorization process goes through a communication channel, goes up to the payer, and then we get it back into Epic. And that's what we really look for. Other thing about a partner, you got to have someone that's going to work with you and is going to listen to you. So, for instance, I've worked with many partners, and I've made suggestions to improve their product line. And they've taken those suggestions and improved. So you want somebody that doesn't say to you, well, I know everything, right?
Oh, sure,
You know, we want somebody such as you who's going to listen to us and take our suggestions and improve services for all your clients.
You know, it's that old saying, God gave you 2 ears and 1 mouth, right? You got to listen to your clients at all times. What are you most excited about on this topic of RCM innovation? Like, is there a single area that gets you fired up?
I think the biggest area right now is artificial intelligence. I think that, you know, if the right technology can come and eliminate the repetitive nature without allowing us to direct our staffs, because again, we have staff shortages. So in this market, it's very difficult to get staff. So if we can get some help with repetitive tasks.
Yes.
And I prefer artificial intelligence over RPA.
Yep.
Bots break.
Yep.
And artificial intelligence is a little bit more seamless, and you don't have to worry about those bots breaking.
Yeah.
So I think that's the most exciting thing that I see.
Are you guys, are you doing some AI like in mid-cycle, back office, front end?
We're starting to do that.
I know we're going to do some together, right? But, are you doing it right now?
No, we're looking at a couple of partners, including you.
Yep.
And hopefully we'll start something up very shortly.
Yep. Yeah, I want to address your thing about bots breaking, because we have to deal with this since we build bots. And it is true, like, some of the partners that we use, they'll say, like, look, your car breaks. We can't be afraid. And we don't even have to get hung up on the word bot. But, one thing that I think is important is that any kind of technology implementation, stuff needs to be maintained. Like all the green lights have got to be there.
Yeah.
It only takes one dictionary, one table, and then you got a blinking red light, right? So it's making sure that there's a service model surrounding any technology. Could be a bot, could be a piece of RPA, could be, to your point, could be a piece of code in a certain node of your revenue cycle. The point is, you always have to watch it, right? Just like you got to watch the oil pressure on your car.
It's just like watching productivity with your staff.
Yeah.
Right. If they don't work the accounts, you're not going to collect. And so you're exactly right. And that's why I think sometimes payers like to change their screens so that the bots are failed.
Right.
And so you constantly have to watch that. So you need some kind of a control in place.
We were talking earlier, Mike, some of us that have been around, right? We're talking about some of these topics for like 20 plus years now, like denials management, right? I wrote an article for HFMA in 2004. I could change the date. That's not good, right, in some respects, but it's also just a reality. There's just still so much to do around denials. And sometimes I say, why don't we, instead of like focusing on denial overturns from a dashboard, lagging indicators, we need to automate denials, right? Denials are going to happen.
Yeah.
You ever think about, like, how do we have a leapfrog moment with a topic like denial management?
Well, I think you've done some of that in your software because you've analyzed the denials and you basically tell us up front, well, this work effort's only going to result in 10%, right?
Yeah.
So why bother with those? And these up here are going to work, you're going to overturn them. So that's helped us out a lot.
Yeah,
but I think you're so right about automating denials and somehow automating it. So for instance, if they need additional information, the payer, that whatever intelligent device goes out there, pulls the chart, gets it to them electronically.
Yeah.
And if the payer will work with us, again, you got to have payer agreement.
Good collaboration,
yeah. Yeah, and some of them, are for-profit.
Sure.
So they're worried about their shareholders.
Sure.
So again, but I think that's ideal situation to go into to try to automate because we continue to see every day a new denial come up. I sometimes think the payers have a room where they have these people just thinking, how are we going to deny today? We got to do this much percentage of claims come in, we're going to deny.
Yeah, I mean, you kind of, this is another one of those topics that there's always a portion of receivables on the hospital side, claims payable on the payer side. The cost to collect and the cost to adjudicate on lower balance, let's just say like even under $1,000. We all like to say the cost to collect's 2.5%. Well, that's because Medicare and Medicaid, the heavy EDI of that, and EDI in general. The problem is the minute that it doesn't get paid in 10 days or less, you see people make 7, 8 phone calls on a $237 account.
You're right.
Right? Not to mention, you said the number of touches. What we're seeing in the data every single day, and clients tell us qualitatively, but we see it in the data, the accounts that are not getting touched, because it's well known now that we have labor challenges and shortages. So part of automation now, in my view, I want to get your perspective. To me, automation is not, and already the white papers are coming out, and I'm glad they are. It's not about just a better mousetrap for follow-up, for example, if we pick one area. It's like we need some AI and machine learning and digital twins just to keep up with the accounts that are not getting touched. We got to automate account inventory that's in many cases just not getting touched.
Well, I agree, and one example of that could help out is COB information.
Sure.
Right? When a payer, and they always pull this stunt, right?
Another topic that hasn't changed in years.
Yeah,
COB.
Exactly. COB.
Yep.
And so they want to delay the claim. They want to get COB to see if there's other insurance information or responsible for the claim. And so if you automate that somehow, okay, you automate that to contact, once you get that back on the 835, or you get a response to your automated responses that you have set up in your system with the payer, and once you get that notification, somehow electronically contact the patient, okay? And that's what I've tried to do with we have a predictive dialer in-house. And we try to do that, automate the phone call to the patient so that we don't have to pick up the phone. And if the patient doesn't respond, then you have no choice but to start billing the patient. So yeah, I think there's a lot of areas where you could improve on that process. Small balances are a major problem with us. You end up, you work the accounts for maybe 45 days, and then you have to outsource it to somebody to have them touch it. And a lot of times, you can't find a partner that really wants to do that small balance work.
2 companies ago when I had, before this and the other one, when I had a consulting boutique in RCM, and I remember it like yesterday, the ratio of reps to open accounts was roughly 2,000, 1,800 to 2,200 accounts. And you see some clients have those ratios. They're in that, they've improved because of EDI. But it's what's scary with sometimes with the consolidation that's happened in the industry, RBOs, multiple business. We see some, and I won't name names to protect the innocent, but I see ratios now. One rep's got 12 to 15,000 accounts. It's like somebody didn't get a good grade in math.
No.
You can't touch anywhere close to that.
I would pull my hair out, and I'd be looking like you.
Exactly.
Yeah.
I just started shaving. So again, it's not a nice to have. It's like, let me ask you just straight up on the labor front. What are you guys dealing with at Cone?
Well, the problem is you've got Arby's paying $19 an hour. You got the announcement that Bank of America is going to pay $22 an hour, right? And so here we are starting off at a minimum wage of $15 an hour. And then what happens a lot of times is these young people come in, they work in patient access, they get a year's experience, and then they fly off. Because you can't retain them because somebody else wants to pay them more. So we have a big labor problem.
Attrition.
And in a lot of cases, what's ending up happening is these outsourcing companies are benefiting from that. Because hospitals can't, as you just mentioned,
but the outsourcing companies are also having some of the same challenges. They hire the same people you hire.
Well, but they also offshore to, India and elsewhere. So to cover those bases. So, it's been a challenge for us, and we're trying to review our pay scales and try to upgrade job descriptions.
Just to stay competitive, right? I think, one of my topics I like is workforce performance, new levels, leveraging gamification. Again, other industries are doing things. Back office call center happens in a lot of things outside of healthcare. And they will use badging, they'll use point systems, they give incentive compensation, right? They use the Hawthorne effect in a productive way, right? And it's just like, healthcare's tricky because people will bring up, well, the union won't let you do, HR won't let you, hey, we gotta start having some tough discussions. So you guys dealing with that?
We gotta think out of the box on those things. I've tried to put an incentive program in place. And again, when you're facing tough margins, 1%, 2%, and then the other issue that you run into is, and I ran this by my CFO, he says, well, Mike, how come the housekeeping staff don't get an incentive? How come these other people within? So you've got that, you know, equality and fairness.
Sure.
So,
but I would argue every department can find a way to have a few KPIs that you hit a stretch goal and you get some of the gain.
Yeah.
I think it's a controversial topic, but with these labor problems, I don't think you can get around it.
Yeah. I believe you're right, and I'm all for it.
So before I lose you, go out 5 years. Where do you want Cone to be? What do you want to have accomplished from an innovation standpoint in 5 years?
I think from my perspective, I would want Cone to be a leader in the technology. We've brought a lot of technology in since I've been there, and I would want us to be on the forefront. For instance, in 5 years, we need to have a bunch of processes that are able to be AI. So we should have that implemented. We should have a digital experience for the patient that's very seamless and like the airlines have. So we need to get there also. And we need to listen to our patients, and we need to listen to what they want, easier way to pay their bills and communication, whether it be a chat functionality or something else. So I want to be at the forefront of that.
It's funny, you know, that's another topic where patient-first initiatives. We've all had the rhetoric in the industry for a lot of years about putting the patient in the middle. But that's also a tricky project. I think a lot of people have done some amazing things. Like you said, it's having a more, I talk about it as, and you alluded to it, having a more retail experience. Because if you do online banking, or you book a vacation, or you book a table for 14 on OpenTable, right? That's pretty seamless, and it's pretty elegant. But what we have in this industry is like, everybody wants to do the right thing, but it's still so fragmented. So everybody's got a mobile app, and then the patient, okay, so you've gotten rid of paper, but now you got 5 mobile apps. Right? So the patient's just going like, really? You know, so how do you see really tackling some of those issues so that the patient has one unified experience?
I think that, you know, as an example, MyChart is trying to get there. You know, MyChart functionality has grown significantly since 2013. So
as a consumer, I know what you mean.
And so you can do a lot of things with MyChart now. You know, you can
on our phone and
test results and things like that. So I think that's the ultimate goal, is to have just one app like that that the patients can go into, instead of having, like you said, you know, right now patients.
But then that puts the onus on people like Epic and others. And I think that this is just challenging because, you know, you can't be all things to all people. You know, even Epic can't solve every use case in healthcare. So, but they can be API friendly, and they can be about data liquidity. And I don't mind being controversial in that regard, because, hey, if we're all going to make healthcare better, I don't think it's you can choose on open data standards. If you're gonna move the needle for the patient, then all the subsystems, they have to be plug and play friendly with any system of record. Right?
And that's just like sharing medical records amongst institutions, because a patient may come to Cone, but he may want to go to Duke if he wants to go, you know, have some heart surgery or something else. So that should be a transparent transferring of medical records. We shouldn't have to have a bunch of red tape to do that.
Yeah, absolutely. All right, final question, because we got the signal. This is like one of those damn rather questions. Like, what question should I have asked you? So what question that I didn't ask you that I should have, in the spirit of this topic?
Oh, that's a tough one. I think you did it very well. But I think the most important thing is I've really appreciated my time getting to know you.
Yeah, likewise.
And I almost got to work for you at one time.
Yeah, I know.
If you remember.
I do.
It was a very short time.
It was another company ago.
Yeah, it was. We won't mention the name, but it would have been my honor to work with you because
Well,
I think you're an innovator, and you brought so much to our business, to healthcare, and I've always thought highly of your product, and hopefully one day I can implement it.
But, you know, there's tricky things. You've always been a big fan. We really appreciate that, including LinkedIn. You're one of our, you know, our LinkedIn cheerleaders, and all of that stuff helps get the word out. I still feel like VisiQuate's like the best kept secret in so many regards. We're trying to change that now.
You will.
There are things like this.
You will.
Having a lot of fun, but really appreciate you coming by.
Thank you, buddy.
And contributing to the dialogue. And you're going to the party, right?
Yes, sir.
Okay. All right. Well, we'll continue some of the dialogue at the party.
Okay. Thanks.
Thanks, Mike.